Imagine, just for a second, losing a massive fraction of your core structural strength over a decade.
Yeah, and the wildest part is you don't feel a single thing.
Right. Not an ache, not a twinge. You're just, entirely oblivious right up until the moment a gentle hug from a friend or maybe a minor stumble on the sidewalk completely shatters a bone.
Exactly. The ground literally gives way beneath you, but it happens microscopically year after year, just entirely out of sight.
So, welcome to this deep dive into the pathophysiology of osteoporosis. Our mission today is to explore exactly what happens when bone weakens.
Which is such a fascinating topic, honestly.
It really is. We're pulling from this stack of medical and historical sources to understand this very specific fundamental imbalance. Basically, we want to figure out how bone loss somehow manages to outpace bone formation, leaving you with a fragile skeleton.
Right, because we so often think of our skeletons as just like scaffolding, just holding up the more interesting organs.
Yeah, a dry, static frame that just stops growing in our 20s and sits there.
Yeah, but that couldn't be further from the truth.
Okay, let's unpack this, because that is the perfect place to start. I want you to shatter that illusion for us. Like, what is actually happening inside the bones of someone listening to this right now?
Well, your skeleton is incredibly dynamic. I mean, it's living tissue continuously undergoing this process called remodeling. Literally every day of your life, your bone is being torn down and rebuilt.
Wow, every single day.
Every day. And this whole operation happens inside this temporary microscopic workspace called a basic multicellular unit, or BMU.
Okay, so it's like an active construction zone.
A very busy one, yeah.
Yeah.
Inside this unit, you have two opposing cellular actors. First, you have the osteoclasts.
Yes.
These are the cells that resorb, or basically dissolve, old bone tissue by secreting acids and enzymes.
Oh, wow.
Right. And second, you have the osteoblasts. And those are the cells that follow behind to lay down a new collagen matrix and mineralize it, which forms fresh bone.
So it's the demolition crew and the construction crew.
Exactly. And the crux of osteoporosis, like the very core of why the disease happens, lies in a glaring biological timing flaw between these two crews.
A timing flaw, what do you mean?
Well, the osteoclasts, the demolition team, they're highly efficient. They can excavate a microscopic pit of old bone in a lightning-fast 2 to 3 weeks.
Okay, 2 to 3 weeks. That's pretty fast.
But the osteoblasts, the builders, they take a sluggish 3 to 4 months to fill that exact same pit back in with new bone matrix.
Wait, really? It's like a city road crew, where the guys with the jackhammers work 10 times faster than the guys pouring the new concrete.
That is the perfect analogy. And if the whole system suddenly speeds up, the city inevitably ends up full of potholes simply because the concrete pavers cannot possibly keep up with the drills.
That makes so much sense.
Right, because resorption is fast and formation is slow. Any acceleration in the overall remodeling cycle almost automatically creates a structural deficit. The fast step just outruns the slow step every single time.
But wait. If this timing mismatch is fundamentally built into our cellular biology, why don't we all just, disintegrate by our 30th birthday?
Right. Well, that's because in a healthy young adult, those two processes are perfectly coupled. They communicate.
Oh, okay. So they talk to each other.
Exactly. The demolition crew might be naturally faster, but chemical signals actually force them to wait for the construction crew to finish filling the pit before they're allowed to start tearing up the next street.
So resorption and formation are balanced.
They are, but certain major life events break that communication. The signals get scrambled, the pace accelerates, and that's when those microscopic potholes start accumulating.
Which I guess brings us to the most famous trigger for this whole cascade.
Yeah, to really understand how the coupling breaks, we have to look back at the 1940s and an endocrinologist named Fuller Albright.
Fuller Albright, okay.
Before his work, the medical consensus was that bone loss was just an inevitable passive consequence of aging. Like, you get older, your bones get thinner, there is nothing you can do about it.
Right, just wear and tear.
Exactly. But Albright published work, notably a 1941 paper in the Journal of the American Medical Association that linked this specific rapid bone loss to the loss of ovarian estrogen after menopause.
Oh, wow. So he realized it was an endocrine issue, like driven by hormones, not just the passage of time.
Right. He proposed that estrogen normally restrains the resorption of bone, and when a woman goes through menopause and estrogen drops, well, that restraint vanishes.
And it took a while to prove that.
It did. Decades later, molecular biologists finally found the exact mechanism that proved Albright right. It involves a signaling pathway called RANK, rankulale, and OPG.
Okay, that is a bit of an alphabet soup.
Eka.
Walk us through how estrogen actually interacts with those acronyms to, stop at the jackhammer.
Sure. So think of it as a cellular communication system. The osteoblasts, the builders, they actually control the demolition crew.
Wait, the builders are in charge.
Yeah. They use a signaling molecule called NCL to recruit and activate the osteoclasts. When NCL binds to a receptor on the demolition cells, it tells them to start digging.
So the builders are the ones handing out the demolition orders.
They are. But obviously the body needs a braking system, and that is where OPG comes in.
Okay, what is OPG?
OPG is a decoy receptor. It basically floats around like a microscopic catcher's mitt, intercepting and grabbing onto the NCL molecules before they can ever reach the demolition crew.
Ah, so if OPG catches the signal, the demolition crew never gets the memo to start destroying bone.
Exactly. And here is the aha moment regarding estrogen. Estrogen is what tells the body to produce all those OPG catcher's mitts.
Oh, I see where this is going.
Right. So in a healthy premenopausal state, estrogen keeps OPG levels high, which suppresses NCL, which keeps a lid on bone destruction.
So when menopause hits and estrogen levels drop sharply,
The catcher's mitts disappear.
Yep.
NCL activity surges unchecked, and suddenly you have a massive recruitment of osteoclasts.
the demolition crew gets a massive hiring boost.
Precisely. And because of that inherent timing flaw we discussed earlier, the whole remodeling cycle accelerates wildly. Women can lose roughly 2 to 3% of their total bone mass per year during the first 5 to 10 years postmenopause.
Wow, that is incredibly fast, like far faster than the gradual decline you see in aging men, I'd imagine.
Oh, absolutely.
It makes complete sense why this has historically been viewed primarily as a postmenopausal condition. But, and this is wild, the sources highlight a totally different extreme that isn't about hormones at all, it's about physics.
Yes.
We have this fascinating accidental natural experiment involving astronauts.
Right. Spaceflight reveals an entirely different way to break the coupling between bone builders and bone destroyers.
But wait, how does floating in a space station mimic menopause? I mean, we're talking about elite, highly fit individuals in their prime.
Well, it all comes down to gravity. There is a principle formalized back in 1892 called Wolff's Law.
Wolff's Law, okay.
Julius Wolff demonstrated that bone adapts its internal architecture to the mechanical loads placed on it. Like every time you walk, run, or lift something heavy, tiny amounts of fluid move through the bone tissue.
So it's feeling the pressure.
Exactly. That mechanical stress physically stimulates the osteoblasts, telling them, hey, we are being used, lay down more concrete.
Ah, the classic use it or lose it scenario.
Literally, put an astronaut in microgravity and you completely remove that mechanical loading. There is zero stress on the skeleton.
Oh, wow.
So the osteoblast activity of the building just plummets because there is no mechanical signal telling them they are needed. But the osteoclast, the demolition crew, they don't care about gravity. They just keep right on working at their normal pace.
So the builders basically go on strike, but the demolition crew works overtime.
Exactly. Well, the result is an extreme, compressed timescale version of osteoporosis. Without countermeasures, astronauts can lose 1 to 2% of their bone density per month in weight-bearing sites like the hips and spine.
Wait, per month?
Per month.
That is staggering.
Yeah.
It completely explains why NASA has those elaborate resistance machines strapped to the walls of the International Space Station.
Yeah, they have to artificially simulate gravity just to wake the builders up. They use these heavy bungee cords and vacuum cylinders to compress the astronauts' spines and legs, basically tricking the skeleton into thinking it's still walking on Earth.
Okay, so whether the trigger is a sudden drop in hormones or a drop in physical load, the mechanism is this structural loss. But this raises a massive logistical question for medicine.
What's that?
Well, if bone thins out gradually for everyone over time, where's the line? Like, how did doctors decide exactly how much bone loss equals a disease?
Oh, that is a heavily debated area. I mean, the term osteoporosis itself actually comes from the 1830s.
Really? That early?
Yeah, a French pathologist named Jean-Georges Chrétien-Frédéric Martin Lobstein coined it from the Greek for porous bone. He was looking at diseased bone specimens under a microscope and seeing abnormally large cavities.
But he was just observing dead tissue, right? He wasn't diagnosing living patients in a clinic.
Right. For over a century, it was just an anatomical description. It actually wasn't until 1994 that the World Health Organization created a strict operational definition.
1994. That feels so recent.
It is. They needed a hard number that clinicians could act on, to run drug trials and prescribe treatments. So they defined osteoporosis purely by bone mineral density, or BMD, which is measured by a DXA scan.
Right, a DXA scan, dual energy X-ray absorptiometry. Basically passing two low-dose X-ray beams through the bone to see how much mineral is blocking the rays.
Yes, so the WHO looked at the density scores and chose a threshold. They decided that a T-score of 92.5 standard deviations or more below the average bone density of a healthy young adult was the cutoff for osteoporosis.
Okay, let's ground that math for a second, because if I hear -2.5 standard deviations, it sounds very abstract. What does that actually look like in human terms?
Sure, imagine lining up 100 healthy 30-year-old women from the thickest, most dense bones on the left to the thinnest bones on the right. That 92.5 standard deviation line is drawn so far down the right end of the spectrum that only the bottom one, or maybe two people out of the 100, would fall below it.
Oh, wow. So it represents a very severe drop from the youthful norm.
Exactly.
And the WHO also invented a whole new category for the people hovering just above that line, correct?
Yes, they created the term osteopenia for anyone with a T-score between NEX 1.0 and NEX 2.5. It provided a very elegant, simple system. You take a scan, you plug a number into a formula, and you get a clear classification.
But wait, here's where it gets really interesting. If we're just drawing a line on a statistical curve of natural aging, aren't we just pathologizing getting older?
Mm-hmm.
You have millions of people whose bones naturally thin as they age, who might never actually break a bone, suddenly being told they have this pre-disease called osteopenia. Like, didn't researchers like Ray Moynihan call this disease mongering?
You just hit on the single biggest controversy in the field. Critics of the WHO definition argue exactly that point. The argument is that relying on the strict T-score cutoff creates immense unnecessary anxiety for aging individuals and drives systemic overtreatment.
Right, like putting people on powerful medications whose absolute risk of ever suffering a fracture is actually quite low.
Exactly. But, I imagine the doctors writing the guidelines see it a bit differently.
How so?
Well, the defenders counter that without a hard diagnostic threshold, you have no way to identify who is in danger. If you wait until a patient's hip snaps to diagnose the problem, you have lost the window to intervene.
Yeah, the classic medical dilemma of screening.
Right. But the 1994 WHO definition had another fundamental limitation that researchers soon realized. It treated bone strength as if it was entirely explained by density.
But density is the only thing a DXA scan can see.
Exactly. But the sources are clear. Two people can have the exact same bone density on a DXA scan, but completely different fracture risks. Density tells you the quantity of bone material, but it tells you absolutely nothing about bone quality.
Quality meaning what? Like how the bone is actually put together.
The microarchitecture, yeah. Imagine a bridge. Density is just weighing the steel. Quality is asking, how are the steel beams arranged? Are they connected properly? How much microscopic rust or damage has accumulated over the decades?
Well, that's a great way to think about it.
Yeah, you can have thick bone that is highly brittle, or you can have thin bone that is structurally sound.
And because of that, the National Institutes of Health had to pivot.
They did. In 2000, the NIH held a consensus conference and officially updated the definition. Today, osteoporosis is defined as a disorder of compromised bone strength, which is the integration of both density and quality.
But you can't easily measure quality at the bedside. I mean, a doctor can't take out a slice of your hip to check the microscopic steel beams.
Right, they can't.
So how do they actually predict who is in danger if half the equation is invisible?
Well, they realized they had to look beyond the scan. So in 2008, a researcher named John Connis and his colleagues at the University of Sheffield developed the FRAX algorithm.
The fracture risk assessment tool.
Right.
How does an algorithm solve the invisible quality problem, though?
By using clinical history as a proxy for quality, FRAX takes your bone mineral density score and combines it with a whole host of real-world risk factors. It looks at your age and gender. It asks if you smoke, which we know actually poisons osteoblasts.
Oh, I didn't know that.
Yeah. It also asks if you have a family history of hip fractures, which hints at genetic bone quality. It asks if you use glucocorticoids, steroid medications like prednisone, which notoriously starve the bone builders and accelerate the demolition cells.
So it's crunching all these lifestyle and genetic clues.
Yes, and it outputs a personalized 10-year probability of suffering a major osteoporotic fracture. So we move from treating a density number to treating a real-world fracture risk.
That makes a lot more sense.
It does. But once we identify that risk, how we actually treat it has led to some massive clinical surprises. When you start chemically manipulating that complex BMU remodeling cycle, the results can be deeply paradoxical.
Oh, really? Give me an example of a paradox.
Let's look at bisphosphonates. These are the most common osteoporosis drugs in the world.
Oh.
They work by lashing onto the bone surface. When the osteoclasts, the demolition crew, try to dissolve the bone, they ingest the drug, which triggers them to undergo apoptosis. They essentially self-destruct.
Wow, so you completely wipe out the demolition crew. That sounds like a pretty great way to stop bone loss.
And for years, they were enormously successful at reducing fractures. But after a decade or so of widespread long-term use, doctors started seeing alarming reports of atypical femoral fractures.
Atypical.
Yeah, people's thigh bones were just snapping right in the middle of the shaft, sometimes from just shifting their weight while standing in the kitchen.
Wait, a drug designed to stop fractures was somehow causing thigh bones to snap?
Yeah.
How does wiping out the demolition crew make the bone weaker?
It goes back to bone quality and microdamage. Just walking around all day creates microscopic cracks in your skeleton. Normally, the demolition crew excavates those tiny cracks, and the builders fill them in with fresh bone.
Okay, I follow.
But if you suppress the demolition crew too effectively for too long with bisphosphonates, that normal microdamage never gets cleared out.
Ah, the cracks just pile up.
Exactly. The microscopic cracks merge into bigger cracks, and over years, the bone becomes incredibly brittle. It's a genuine case where treating excess resorption created a brand new problem of too little remodeling.
That is wild.
Yeah, which is why it's now standard practice for doctors to mandate a drug holiday, taking patients off the medication after several years to let the normal repair cycle resume.
Unbelievable. So by freezing the system to save the bone, we accidentally turned it to glass.
Basically.
And the sources mention another paradox with a hormone treatment, right? Teriparatide.
Yes, teriparatide is a synthetic fragment of parathyroid hormone, or PTH. Now, basic biology tells us that if a patient has continuously, chronically elevated PTH in their bloodstream, it signals the osteoclast to go into overdrive. Chronic exposure destroys the skeleton.
So PTH is normally a signal for demolition.
Right. But researchers found that if you give that exact same hormone as a once-daily subcutaneous injection, like a sharp, short pulse rather than a chronic drip, it does the exact opposite.
Wait, how can the same hormone destroy bone one way and build it another?
It all comes down to cellular timing. A quick, sharp spike of PTH rapidly wakes up the osteoblasts, stimulating their lifespan and building activity. Because the pulse fades quickly from the bloodstream, it disappears before the slower osteoclasts have time to fully react to the signal.
Oh, that's clever.
Yeah, by the time the demolition crew gets out of bed, the signal is gone, but the builders are already hard at work. It actually builds brand new bone.
That is mind-bending. The rhythm of the drug completely reverses its biological function.
Science is amazing like that.
It really is. What about the basics, though? Because for decades, every commercial told us to just take calcium and vitamin D pills to build stronger bones.
Yeah, that's another area where the science has heavily evolved. For a long time, we thought we could just give the construction crew more Brix calcium and more Formin vitamin D to build stronger bone.
Makes logical sense.
But in 2018, the U.S. Preventive Services Task Force reviewed the accumulated evidence and actually recommended against daily low-dose vitamin D and calcium supplementation for the primary prevention of fractures in healthy postmenopausal women.
Wait, they said don't bother taking the supplements.
Basically, yeah. They found insufficient evidence that those common low daily doses actually provided any meaningful benefit in preventing fractures for the general population.
Wow.
Now, obviously, addressing a diagnosed clinical deficiency is a totally different medical story, and getting nutrients through your diet is vital. But the cultural idea that vitamin pills were a magic bullet for everyone's skeleton, that was heavily challenged.
That is wild. So the supplements everyone thought were magic bullets might not be, and the powerful drugs we use require holidays so your femur doesn't snap.
Pretty much.
These paradoxes just highlight how deeply misunderstood osteoporosis can be by the general public. Which I think brings us to the misconceptions that you, listening to this right now, might currently hold. Let's do some rapid myth busting based on the data.
I love myth busting. First major myth. Osteoporosis is just an old woman's disease. While postmenopausal women are absolutely the highest risk group, men develop osteoporosis too, particularly after age 70.
Right.
But because of the societal stereotype, men are significantly underdiagnosed and undertreated. Their doctors simply forget to look for it.
That's a huge blind spot. Okay, second myth. It's the same thing as osteoarthritis. I hear people conflate these two constantly just because they sound the same.
Right, they both start with osteo, meaning bone, but they are totally unrelated. Osteoporosis is a bone density and microarchitecture issue. Osteoarthritis is a joint and cartilage wear and tear issue.
So totally different tissues.
Exactly. You can have both. but one does not cause the other. People also confuse it with osteomalacia, which is a mineralization defect causing soft, bendy bones, usually from severe vitamin D deficiency.
Haven't heard of that.
Yeah, but osteoporosis means porous bone, not soft bone. The remaining bone is fully mineralized, there's just less of it.
Okay, got it. Third myth, and this is the one that really gets people. I will feel it happening. My bones will ache as they get weaker.
Completely false. It is 100% silent.
Silent.
The bone loss itself causes absolutely zero symptoms. You will not feel a thing until the day you suffer a fragility fracture.
And fragility fractures when you break a bone from a force that a healthy skeleton would just shrug off, right? Like coughing too hard or awkwardly stepping off a curb.
Sadly, yes. And we have to spell out the grim reality of what happens when that fracture finally occurs, particularly a hip fracture in an older adult.
Yeah, what are the true real-world stakes here?
The stakes are life and death, as well as quality of life. Hip fractures are consistently associated with a substantially elevated mortality rate in the year immediately following the break.
Wow, really?
Yes, often due to complications from being bedridden, like pneumonia or blood clots. And for those who survive the first year, a massive share never regain their prior level of independence. They end up requiring long-term nursing care. The disease changes the entire trajectory of their life in an instant.
That is sobering. So we've covered how osteoporosis is a microscopic structural breakdown, where the fast demolition crew outpaces the slow rebuilding crew. We've seen how that is driven by hormonal drops or lack of physical load. And we've seen how modern medicine has evolved from just looking at a T-score on an X-ray to treating the holistic algorithmic fracture risk.
Right. We've realized that bone strength is a complex living ecosystem, and preserving it requires a lot more nuance than just looking at a single density number.
Absolutely. But there's one final piece of this puzzle from the sources that really stuck with me, and it fundamentally changes how we should all view our own skeletons.
What's that?
Peak bone mass. The absolute maximum density and strength your skeleton will ever achieve in your entire life is reached by age 25 to 30.
Right. After that point, the bank account is locked, and for the rest of your life, you are just managing the withdrawals.
Exactly. So your childhood and adolescent habits, your nutrition, your weight-bearing exercise during your school years are actively determining your geriatric fracture risk decades in advance, which leaves us with this incredible paradox to chew on.
Oh, what's the paradox?
Well, consider this. Osteoporosis is traditionally viewed by society as the ultimate geriatric disease.
Right.
But given that your maximum bone bank account is locked in by age 30, and combining that with the fact that preventing bone loss is now a top scientific priority for getting young elite astronauts to Mars,
Right.
osteoporosis is actually a pediatric disease and a space-age frontier problem that just happens to reveal itself in old age.
That is a fascinating way to frame it. It is a lifelong structural challenge, not just an end-of-life inevitability.
Something to think about the next time you go for a walk and put some physical load on those bones. Thanks for joining us on this deep dive, and keep questioning the world around you.